Hello, my name is Dr. Veronica Hood, and I'm the Scientific Director at the Dravet Syndrome Foundation. Thank you for joining us today for the third session in our three-part educational webinar series on AAV-mediated gene therapy for developmental and epileptic encephalopathies. This educational series is provided by the Dravet Syndrome Foundation in collaboration with Encoded Therapeutics and is intended for healthcare providers. This educational series will be led by two experts in the field, Dr. Sarah Weckhuysen from the University of Antwerp and Dr. Michael Lawler from the Medical College of Wisconsin. If you have not yet had a chance, please watch the first two sessions of this series, in which Dr. Lawler introduces the basic concepts of gene therapy and AAV-mediated gene therapy, and discusses the translational and clinical considerations. Recordings can be found on the Dravet Syndrome Foundation's website. Please submit any questions you may have through the intake form on the DSF website by December 15th, and we will post responses in March. During today's session, Dr. Weckhuysen will present on developmental and epileptic encephalopathies as potential candidates for AAV-mediated gene therapy. Dr. Weckhuysen obtained a PhD on the topic of genetics and epileptic encephalopathies under the mentorship of Professor P. De Jong, who discovered de novo SCN1A mutations as the genetic cause of Dravet syndrome in 2001. Now, Dr. Weckhuysen serves as assistant professor at the University of Antwerp in Belgium and heads the epilepsy research team of the Applied and Translational Neurogenomics Group at the VIB Center for Molecular Neurology in Antwerp. The developmental and epileptic encephalopathies are of specific interest to her group, as she strongly believes that the study of the underlying genetic mechanisms can be the entry point for the development of more potent targeted therapies. Additionally, Dr. Weckhuysen is a member of the Dravet Syndrome Foundation Scientific Advisory Board. And with that, I will turn the session over to Dr. Weckhuysen.
Hello, everybody. I'm Sarah Weckhuysen. I'm a neurologist and a researcher, assistant professor in the University of Antwerp in Belgium. And I have a specific interest in genetics of epilepsy. And for the talk of today, or presentation of today, I'm going to talk to you about the developmental and epileptic encephalopathies and their potential as candidates for gene therapy. So these are my disclosures. I received consultancy and speakers fees from several companies that you see listed here. At first, I think let's discuss shortly what the developmental and epileptic encephalopathies are. They're actually not a single disorder. It's more of a group of a very heterogeneous group of different disorders that are all characterized by refractory seizures and developmental stagnation or regression, both most often occurring very early in life, either the neonatal infant or childhood stage. These children are severely affected. They have a high rate or different types of comorbidities, and very importantly, also including intellectual disability, autism spectrum disorder, or other behavioral problems. But they also often have other neurological deficits like ataxia, quadriparesis, movement disorders, etc., etc. They're individually rare. You see a few incidences here of different disorders, Rett syndrome, Dravet syndrome, etc. So individually rare, but altogether, I would not say they're common, but they're not that rare anymore. And they're a group of disorders that give rise to a very high disease burden. They're variable in severity. There's children or patients with mild ID or profound ID. They might have, especially in the beginning, most of them have very frequent seizures, but at the end, seizures might be well controlled, and some other children have treatment-resistant epilepsy, and also the neurological motor deficits, for example, can be very variable. even when you look at, or within single gene entities, and then when you look at the figure at the right-hand side, you see a few of them listed. Here they only looked at age of onset of either the epilepsy in blue or developmental delay. You see that although for some entities like SCN8A, 2A, or KCNQ2 and 3, or CDKL5 related disorders, both the epilepsy onset and developmental delay onset is quite early in life in almost all of the children. In some of the other genetic entities, this can vary significantly among patients. In the disorders that you see listed here, epilepsy onset is most often very early, while the developmental delay follows. Most, if not all, of these disorders have a genetic underlying cause. That said, in only 40 or 50% of patients, we can make a genetic diagnosis with the currently available techniques. In last few years, I've seen a tremendous increase in the number of DEE genes that have been described. But as you can see, based on the numbers here, there is still a diagnostic gap. Genetics in DEE, nevertheless, has learned us a lot, I think. And first of all, over the last few years, there have been many proofs, many pieces of evidence that the genetic underlying variant itself has some kind of influence on neurodevelopment. And I list a few of the pieces of evidence here. First of all, if you look within some of these entities that have been described in the meantime, for example, ST's BP1 encephalopathy, which is not uncommon, you see that some of the children there, they do show developmental delay prior to seizure onset, or some of them even do not develop seizures at all. So the mutation only leads to neurodevelopmental delay. In some other developmental and epileptic encephalopathies, seizures might stop quite early in the disease course or become really infrequent, something that is seen, for example, in several children with KCNQ2 encephalopathy. But on the other hand, almost all of them present severe intellectual disability, showing that there's no direct, or no direct is not maybe the word, no pure correlation between seizure frequency or severity and the degree of developmental delay. And also what's very important is that there is a clear overlap between the genes and the pathways that have, over the last few years, been implicated in the developmental and epileptic encephalopathies, and then in cohorts that have been studied in the context of intellectual disability, for example, or autism spectrum disorders. And you see a figure here at the right-hand side. It comes already from a paper that has been published several years ago, so the numbers are not up to date, but it's clear that several or many genes have been involved either in epilepsy, or that's not the word, and in epilepsy and in autism disorders and in developmental delay disorders and even schizophrenia, as you see there. And all this knowledge or insights that we generated over the last few years together, it also led to significant changes in our terminology, also the terminology that is used by the International League Against Epilepsies. As an illustration, until a few years ago, we thought of many of these disorders as being epileptic encephalopathies. And what does this term imply? It implies that the epileptic activity itself in an immature brain, it leads to developmental problems. And most often this has, a genetic cause. And what happens is what you see here. There's a gene mutation leading to a protein variant. This leads to some structural or functional changes, which in turn lead to seizures. And the idea was that frequent seizures lead to the developmental encephalopathy. And obviously, if this is the case, then you can assume that if you treat seizures aggressively enough, and if you can control them, that you would solve or prevent the developmental encephalopathy. Now, in the last, or again, with all the insights that we generated, it was clear that for many of these syndromes or entities that we introduced in the slides before this is not clearly the case. And the ELA introduced this term of developmental and epileptic encephalopathy. And what does this term implies? This implies that the seizures or the epilepsy at the one hand and the developmental encephalopathy at the other hand are two interdependent results of the underlying gene mutations. And there's two parallel pathways involved that can influence each other. But it's clear when you look at this figure that you might treat seizures very, very aggressively. This will probably not solve all problems. And we should try to target the underlying gene mutation to really resolve also the developmental problems. This complexity is also reflected when you look at the neurodevelopmental trajectory of these two groups. If you look at the first figure at the left, this is the classic developmental trajectory of a patient with a clear epileptic encephalopathy. So in green, you see the normal neurodevelopment over the years, and the child develops different skills until adult age. And then the epileptic encephalopathy, what happens is that at the time of a seizure, you see a regression, and then neurodevelopment takes off again. And there's another seizure, and if they're very frequent, of course, you clearly see a regression or a stagnation of development. But if you treat the seizures, you can improve definitely cognitive outcome. And this is something what you, for example, see in many patients with Dravet syndrome. And when we treat the spasms of these children, you see often that, or sometimes that development even retakes and the child develops normally again. This is not the case in patients with the developmental and epileptic encephalopathy. And there's different trajectories here. And for example, if you look at the first figure in this other concept, some of these children, they start off normal, they have a normal development initially, but then there's seizures, you see a regression, and from then off you see that there is some kind of delays that can be exacerbated with every seizure that follows. In other children, there's a neurodevelopmental delay from the beginning that's then exacerbated by seizures, but in between seizures they can improve a little bit. Or then there's the group at the total right side. There's neurodevelopmental delay from the beginning. And with every seizure, you see that there's a clear impact and an exacerbation without recovery of the trajectory. Obviously, and this group or the right-hand group, aggressively treating seizures can have some impact on development, but will not solve the whole problem. And we hypothesize that targeting the underlying cause or mechanisms might improve both seizure and non-seizure manifestations. Over 100 genes have been identified in the meantime in the developmental and epileptic encephalopathies. As I said, it's not a single disorder, it's really a mixed bag of different disorders. Many types of genes and pathways have been involved. We can identify two big groups, apart from other less frequently affected pathways, and that are the ion channel genes, like genes as SCN1A, casein A2, Q2, etc., or synaptic transmission genes. Especially for the ion channelopathies or the channelopathies, it's very important to realize that particularly in these genes, and you see a few examples in the figure, different types of variants in this gene can be associated with different phenotypes. And this can also have impact the treatment choice. For example, casein Q2, SCN2A, SCN1A, sorry, like you see there, depending on the variant or the pathogenic variant that the individual carries, the phenotype can span from a very self-limiting epilepsy, so it's like the self-limiting familial neonatal seizures, to a very severe disorder like casein Q2 encephalopathy, SCN2A encephalopathy, etc. And the type of variant plays a very important role here. And when saying type of variant, I'm thinking of the distinction between loss of function or clearly loss of function variants at the one hand, like truncating variants, stop mutations, splice site variants, flame shift variants, or missense variants at the other hand. And within the group of missense variants, we can also distinguish variants that lead to a gain of function of the particular gene or the protein that it encodes for, or a loss of function. And depending on the type of variant you have, you get a different phenotype. And why is this important? Because the variant type in many of these entities also influences the response to a particular anti-seizure drug that we also already, for some of these disorders, have to our disposal. And then I'm thinking, for example, the use of sodium channel blockers. Sodium channel blockers will be very efficient, or will be more efficient in patients with variants in SCN2A that lead to a gain of function. So SCN2A, very simply said, it's function, or it's open too much. The channel is open too much. If you block it with a sodium channel blocker, this is effective on seizures, while it will not work or might even lead to adversary or worsen the disorder in variants that have a loss of function effect, where the channel already is not functioning well enough. Altogether, I think it's clear that the developmental and the epileptic encephalopathies, they present a significant unmet need. Why? Because almost all of the currently approved therapies that we have available to use in these children, they ultimately reduce seizure frequency, and they might, by doing this, have some, or to some extent, an impact on neurodevelopment, but they don't address the underlying mechanism. And eventually, that's what we think we would need to have a clear impact on neurodevelopment. And why is the unmet need so big? I list a few items here, and we've just discussed them in the previous slides. The phenotype is highly variable, as I said. Severity might fluctuate or might be progressive in severity, but eventually many, if not all of these children have severe cognitive and behavioral impairments. Many of them are refractory even to the conventional anti-seizure medication. Many of them are on polytherapy, improving the risk of side effects. As I said, they have often a lot of comorbidities. Besides the neurodevelopmental problems, many of them have motor deficits, movement disorders, etc. So they often require multidisciplinary care, both for the seizure and the non-seizure related manifestations. And altogether, it's clear that this has a significant impact on many aspects of both the patients and the parents or the caregivers. It's an incredible burden also for parents taking care of these severely affected children, with a subsequent, of course, very high humanistic and economic strain. And although, as I said previously, by now we know about more than 100 genes for the developmental and epileptic encephalopathies, so far there's few or non-gene targeting approaches approved yet for these entities. That said, I think there's quite some evidence out there that it might be the way forward. You know probably that there's already many clinical trials of gene therapies in other disorders or genetic disorders, but also neurological disorders. Listed a few there. Some of you might know Zolgensma, gene replacement therapy, and Spinraza, an azotherapy, antisense oligonucleotide therapy for spinal muscular atrophy. There's Brineura, an enzyme replacement therapy for cerebral lipofuscinosis, or the ABO-102 is also a gene replacement therapy for Sanfilippo syndrome. So, as discussed before, knowing that it's not only the seizures that impact development in the developmental and epileptic encephalopathies, but it's truly the underlying gene mutation. This really is very promising for a place of precision gene therapies to really address the whole patient and all comorbidities altogether. And in the last few years, there have been quite some progress made, and this paralleled our greater understanding of underlying mechanisms in the developmental and epileptic encephalopathies. And again, a few examples here. There are some clinical trials that initiated with either antisense oligonucleotides or gene regulation therapy for SCN1A related Dravet syndrome. It's like the prototype of the developmental and epileptic encephalopathies. There's a clinical trial of a regulated gene replacement therapy for Rett syndrome and antisense oligonucleotides for SCN2A related disorders. So many advances are being made there. Of course, this does not remain without challenges. First of all, I think we have to realize that in many of these children, the time to diagnosis is often still slow. And this can have many reasons. So first of all, access to genetic testing, of course, it's not the same all over the world. And besides that, also the phenotype, as explained, it can be very variable, and developmental problems sometimes only become evident after a few months, even years. So the clinicians don't always think about the specific genetic etiology yet. And last but not least, more than 50% of patients still with the currently available diagnostic techniques, they remain without a genetic diagnosis. And of course, if you don't have a genetic diagnosis, you cannot think about specific gene therapy. As discussed again, the outcome in these individual patients, it can be very variable. And although a genetic variant definitely plays a role, it definitely does not explain the whole variability. Probably other genetic factors or environmental factors play a role. So of course, what is essential is that we need patient registries, natural history studies to compare outcome measures with. And what we also do not totally understand yet is the window of opportunity. And what is a time window for an optimal outcome for these patients? And probably this really depends on the underlying gene. I think we all assume that the earlier you treat the patients, the better or the higher the impact will be. This is something that we already see, for example, in Dravet syndrome. In Dravet syndrome, which is caused by mutations in the gene SCN2A, that use of sodium channel blockers for seizures can worsen outcome. And sodium channel blockers are obviously a type of drug that is very commonly used in child neurology practice. So the earlier you make the diagnosis of Dravet syndrome, the more likely you are to avoid these drugs. Despite the fact that we assume that we should treat as early as possible, there is some evidence from animal studies that is very promising, that at least in some of the genetic DEEs, postnatal initiation of therapies can still influence neurodevelopment. And this is very important. I give two examples here. One is in the DEE caused by mutations in SINGAM1, and the other one is in Angelman syndrome. They created mouse models of these disorders, and I won't go into detail, but they show that replacement of the wild type gene and protein only later in life did still ameliorate neurodevelopmental outcome measures. So as a concluding slide, I think we can agree that gene therapies for the developmental and epileptic encephalopathies, they're very promising, but there are some challenges still. First of all, I think the goal should be to try to provide early genetic diagnosis, as this will improve patient care. The earlier we make the diagnosis, the earlier that at least we can think about the possibility of initiating a precision therapy, especially now that several of these gene therapies or ASO therapies are starting to be introduced or used in clinical trials. And if we make a genetic diagnosis, and this brings me to the piece on the right upper hand side, it is very important that we talk with our geneticist. What does a particular variant in a particular patient mean? Is it truly pathogenic? Can we be sure this is really the cause of the underlying, the cause of the phenotype of the patient? If we're sure it's pathogenic, and then I think specifically about the ion channel related disorders, do we know what effect the variant has on gene function? Is it a loss of function variant or a gene of function variant? And this might have important consequences for the choices of treatment. I refer to specific anti-seizure medication, but of course, this is also true when we think about future gene therapies. A gene replacement therapy will only be beneficial if the variant in question will lead to a loss of function or a lack of the protein. Besides that, I think in the development or specific future gene therapies, there's still some challenges or technical challenges still. For example, if we want to reduce possible side effects, and specifically when we think about gene therapies that are very, in some way invasive, we might think or aim for self-specificity. And again, as an example, I use Dravet syndrome, and this very famous DEE, the prototype of the DEE, where we know that the affected gene is SCN1A, and SCN1A is expressed specifically in inhibitory neurons. So ideally, we want to express our gene of interest or a gene therapy, we want to apply it specifically to the inhibitory neurons. Or we might even particularly only target specific brain lesions. I think all this, taking all this into account, what is key here, or the key message that I always give when talking to clinicians, is that collaboration and coordination is really key. We need to collaborate between the neurologist, pediatric neurologist, adult neurologist, and our medical geneticist, or the whole team in the medical geneticist department, both at the time of diagnosis, but also when thinking about treatments and thinking about potential participation in clinical trials of gene therapies. And when we take care of these children, we have to think of these children or adults when they become adults in a multidisciplinary way, in a holistic way that includes, for example, also a neuropsychologist, given the important comorbidities on different aspects of neurodevelopment. And with this concluding slide, I want to end my presentation. I thank you all for your attention.